Okay, good. Now, this is another discussion today about pharmacology in anesthesia. We are going to focus on drugs which are used in anesthesia. For example, you have come across somebody who is being excised a tissue from the body, the drug which is inflicted there so that the person does not get pain is a local anesthesia. Or for example, in dermatology, in tattoo, in dentistry, or sometimes in spinal anesthesia, we will briefly focus on this type of drugs which are used in this activity so that the patient becomes comfortable, does not have a sensation or a pain for the purpose for the activity to be of effective with minimal pain. So with minimal pain. So by definition, we will see that by definition, you will see that local anesthesia is a drug which is upon application topically or sometimes with local injections can cause a reversible loss of sensation, loss of pain, or some in a localized part of the body, which is happens because of generalized blockage or conduction of nerve impulses in a specific localized site of area of interest, without any structural damages to the nerves or to the neurons. So clinically, there is blockage of pain sensation from that site, or sympathetic vasoconstrictor impulses to specific areas of the body, leading to loss of sensory as a motor, as well as motor impulses. And this one reduces perception of pain, reduces perception of a sense of sensory, so that the patient can be worked on comfortably. So examples of clinical use of this type of drugs is like, for example, we use this type of drugs called local anesthesia in nasal mucosa and the hood margins. In nasal mucosa and the hood margins. For the example, if you want to do something on the nose, you can use it, or sometimes on the hood margins, you can use it so that you can be able to raise the wound very comfortably. You can also do it in infiltration in the vicinity of the periphery of the nerves, headaches, and the major nerves trunks. It can also be used in epidural or subarachnoid spaces surrounding the spinal nerves, and also can be used in local anesthesia, that is intravenous injections in arms and legs to cause something called back broke. So let us check the comparative of local anesthesia versus general anesthesia. So in terms of general anesthesia, site of action is central nervous system, whereas in local anesthesia it is peripheral nerves only. So the area is in general anesthesia is the whole body, and in local anesthesia it is restricted to a specific area of choice. So the patient is conscious on local anesthesia, but it is lost in general anesthesia. So preferential use, it is commonly general used. General anesthesia is commonly used in major surgeries, whereas local anesthesia is used in minor surgeries. So in non-cooperative patient, general anesthesia is used, and also in it's not possible to use local anesthesia in patients who are not cooperative. So poor patient are the risky general anesthesia and safe local anesthesia, and care for vital functions is very essential when you're doing general anesthesia, but not needed in local anesthesia, unless if there is a specific type of organ which is affected when you're doing that specific local anesthesia. That is the time the care of vital functions of the organ is needed. So historically, the origin of this local anesthesia is France in Western Europe by the year 1750 to 1985, 850. A chemist and a physician collecting samples of coca leaves for experiment, and isolated active principle of coca leaves synthesized to drug patient to feel more relieved of pain when taking surgeries. So in 1880s, in 1860, German chemist Albert Niemann successfully isolated the active principle of coca leaf. He named it cocaine and ester of benzoic acid and methanol, So what are the drugs in terms of classification of these local anesthesia? We have injectables, like low potent short duration like procaine and propine. We have intermediate potency like lidocaine and also precolcaine, and we have high potency and long duration like retracaine and bufocaine. And the examples in this table drugs are lovicaprine, lidocaine, and mebuloprine, and duloxetine, and cyclocaine, which is cyclocaine is more of in the family of cocaine. So we have a surface anesthesia product like soluble, which like cocaine, lidocaine, tetracaine, and benzoate, and we have insoluble like benzoic, butyroaminobenzoate, and oxidamine. And then we have miscellaneous drugs like chlorpheniramine, chlorpromazine, and dipromazine, which works also as anesthesia in some perspective of human being. So another classification can also be classified according to the chemical structure these molecules have. For example, the molecule like ester-related types of molecules of this is like ester-related, like short-acting, metabolized in the plasma and the tissue fluid, excreted in the urine. Those are the ester. Then you have amide, like long-acting, metabolized by liver enzymes and excreted in the urine. So remember, all these ones are weak bees. So we have esters like procaine like novocaine, tetracaine, and benzoic procaine, and we have amide linkage like lidocaine, mepivocaine, and buvocaine, and ethinocaine, and propylocaine. So chemistry of rockwell anesthesia in terms of clinical significance is that the cross sensitivity of RNG with the esters linkage occurs with the drugs in the same chemical classes, and the esters are metabolized to common metabolites like PAPA. RNG rarely occur in the amide linkages classes, and the transcription duration of action of esters are rapidly metabolized in the plasma by cholinesterase enzyme. So the amines are mostly slowly destroyed by the liver and microsomal enzyme P450 enzymes, enzymes of these plant. So the mechanism actions of local anesthesia is that, as you know, the entry of sodium is essentially in action potential. So the two things do happen. Number one, rate of and rise of speed and maximum depolarization decreases, slowing conduction. Finally, local depolarization force to reach the threshold, and that means there is blockage of conduction. So local anesthesia interact with the receptors within the voltage sensitive sodium channel and releases the threshold, opening the channel that is in the and also sodium permeability decreases and ultimately stops in the response to stimulus of impulses. Impulse conduction is interrupted when a critical length of fiber is blocked in 2 to 5 nodules of labia. So you can see this is a nerve of, we call it a nerve cell. You can see that the axon, the sympathetic bulbs, the membrane, that is Schwann cells, and then the nerve. So you can see how this one takes place about this one. So for you to understand this one, is to understand the sodium pump channel well. So high concentration of calcium reduces inactivation of sodium channel. Blockage is not due to hyperpolarization, is due to unturned as sodium channel are not blocked. Blockage is related to potassium of particular drug. Like for example, 7.6 to 7.8 in reconic fast-acting drug more associated form, and 8.1 to 8.9 slow acting like that is the PKU of the drug. So the summary of mechanism of local anesthesia is that all local anesthesia are membrane stabilizing drugs. There are membrane stabilizing drugs. That's one of the things you should understand. And this one slows down the speed of AP, ultimately stopping AP generation. So this reversibly decrease the rate of depolarization and repolarization of excitable membranes. So act by inhibiting sodium influx through the sodium specific ion channels in the neural cells, 14 gated sodium channels. When the influx of sodium is interrupted, action potential cannot release and signal conduction is inhibited. So, local anesthesia binds local at the inner surface more rapidly to sodium channel inactivated state and slows it reversal to the resisting state. That is, the refractory period is increased, leading to state-dependent blockage. So many other drugs have membrane stabilizing properties or one used as a local anesthesia, like which is not used is like propranolol, which is used in atrial fibrillation in heart conditions, is a beta blocker in heart condition, which is commonly used in hypertensive heart disease. So, what are the factors which influence the first, the effect action of local anesthesia is liquid solubility of these drugs, uh, and also a pH, and also vasoconstriction, and also inflammation at the rock of site. Because, for example, inflammation will affect the blood flow, will affect the all these are the pH of them in that point of the body. So, oral anesthesias have effect on nerve acting via the sodium channel sensory endings and nerve tracts, neuromuscular junctions, and ganglion receptors. That is where they work. They work on channel sensory endings, nerve tracts, neuromuscular junctions, and ganglion and receptors. So injected near mixed nerve, like anesthesia of the skin and the paralytic and the paralysis of blood muscles, and the sensory and motor fibers are equally sensitive depending on diameter and type of fiber, which is there. So smaller fibers are more sensitive than larger ones, and the frequency depends on meditated nerves are blocked earlier than non-meditated nerves, and autonomic fibers are more susceptible than somatic ones. So functions lost with local anesthesia is what? Pain perception. So in local anesthesia, you lose pain perception, you lose temperature perception, and also touch perception, and the proprioception is lost, and also skeletal muscle is lost. So those are the things which are lost when you have local anesthesia. The Honda of blockage is initial. These fibers are blocked pain, which blocks the pain and sympathetic vasoconstriction. The GA fibers pain temperature, touch, pressure, and vibrations, motor fibers for the muscles, and the tongue, if it is affected, is blocked by local anesthesia. It can interfere with the bitterness, sweat, and the soreness of the tongue. So there is a various side effect of local anesthesia, that is undesired effect of local anesthesia. Like in central nervous system, it can stimulate the central nervous system, more sensitive to the cardiac, and it is low dose related with the spectrum of the effect or effect are due to depression of neurons. And the fast and apparent central nervous system stimulation can lead to convulsions in most of the cases, and also can cause, in other people, can cause depression and cause death due to respiratory depression. So premonitory signs include like ringing in the ears, metallic taste, and numbness around the lips. So cocaine can cause euphoria, that is the inability to stimulate, due to inability to stimulate CNS, and lidocaine can cause sedation and even at a toxic dose. So in the cardiovascular system, there are side effects like arrhythmias, which can be either directly related, but don't worry, later on we'll see that arrhythmias is also treated by this type of, sometimes you can treat arrhythmias using this lidocaine, this type of local anesthesia. So arrhythmias, which is directly effect related, most resistant than CNS, so decrease in cardiac stability and contractility. So in this case, arrhythmias can be because of depression of the CNS, resulting to decrease in cardiac excitability and contractility. resulting to arrhythmias. It can also decrease the conduction rate and also increase refractory rate, and also can cause arrhythmias if concentration is high enough. Not except cocaine, exception it stimulates the heart. So all others except the cocaine stimulate the heart. Sometimes even these these local anesthesics can cause hypertension by causing atrial dilatation, resulting to what? Into reduced peripheral resistance. An example is procaine and lidocaine, and the blockage of postganglionic sympathetic fiber functions, CNS depression, and avoid of anti vasoconstricted preparations. And the cocaine is exceptional in this case because it produces vasoconstriction, blockage, catecholamines, and reuptake. Another one, it can cause methaglobulemic. That's some local anesthesia can cause a metabolite insufficient or oxidizing effect, which can cause hemoglobin to metaglobin and compromising ability to carry oxygen. Maybe a problem in cardiopulmonary reserve is limited. Treating with oxygen and methathiron group convert metaglobin to hemoglobin, like precocaine, benzocaine, and lidocaine have been implicated in this. So another one, it can cause hypersensitivity, can cause LAS, angioedema, dermatitis, and rare anaphylactic shock, and sometimes typical asthmatic attack. In another one is neurotoxicity. Local anesthesia can cause neurotoxicity, which is dose dependent, especially in the central nervous system, peripheral nervous system, and also the mechanism is not well understood. So permanent neurological injuries is rare and may account for transient neurological symptoms after spinal anesthesia. That is counter-equina syndrome. So let us look at the pharmacokinetics of local anesthesia. So in absorption and the distribution of these local anesthesia, that surface anesthetic from mucous membrane and abraded areas is where the absorption of these types of local anesthesia from the areas which is affected, like food or even mucous membrane from the eyes, from the mouth, from the GIT, along the rectum, all that. Depends on the blood flow to the area, total dose, and the specific drug characteristics are the factor to this influence the absorption of this drug at that local area. So protein has a poor penetration in mucous membrane, and the protein is negatively bound to plasma protein, but amines are bound to alpha A acyl glycoproteins. Glycoproteins are the ones which act on the membrane transport and communication between the intracellular and the extracellular proteins in terms of communication. So distribution, these local anesthesia are widely distributed in the body. That means they are lipopedic because they enter the brain, heart, liver, and the kidney, and followed by muscle and the other viscera in the body. So metabolism, depending on the types of organism in terms of chemical histories, like esters type A local anesthesia, type local anesthesia is that they are hydrolyzed by cholinesterase in plasma to papa derivatives. These are pseudocholinesterase by beta-cholinesterase. These are enzymes and destroy this, break down these hydrolyze these local anesthesia. It generally short acting and low synergetic toxicity. Prolonged effects seen with genetically determined diseases or altered esters like cholinesterase inhibitors. So amide type local anesthesia is bound to alpha-1 acylating glycoprotein and raised by liver microsomal enzymes, that is the P450, and long-acting and more synthetic toxic than esters. High fast metabolism on oral ingestion. So that means they are, if you give them orally, they will be destroyed before they do whatever they are supposed to do in the body. So let us see individual anesthesia like natural occurrence from L-thyrochloris, coca, medical use limited surface of topical anesthesia, and like cornea and nasopharyngeal. Constriction of cornea vessels and the sludges of drying and toxic action on heart may reduce rapid and endocardiac failure. the haptic inhibition and noradrenaline. So central nervous stimulation of vasomotor, vomiting, and temperature centers. Initially, a euphoria followed by dysphoria that is due to the haptic. Avoid adrenaline because cocaine already has a vasoconstrictor properties. Sometimes you may come some of reginokins which are combined with adrenaline, that one should be avoided. Marked pyrexia is associated with cocaine overdose and not used preceptively. That is about cocaine. So procaine, that is an ester, the relatives topically ineffective in its disadvantage used to do nutrition because of low potency and short duration, but most commonly used for spinal anesthesia. So short local duration produces significant vasodilation and renal used to prolong the effect. So systematically toxicity negligible because rapid destroyed in plasma and procaine penicillins. So this one is a procaine, which is a ester, and those are the characteristics. The other one is renocaine, which is the most commonly used in our setup, and this one is the effective by all routes. It can be either used topically, you can infiltrate, and you can also use the spinal. And fast onset is 3 to 5 minutes, 15 minutes, and more intense, longer lasting than 60 minutes than procaine. When it is added to adrenaline, that's in a dose of 1 to 2,000, 20,000 prolongs the action but for 2 hours. But the biggest problem, it can also cause a rebound bleeding. So more potent than procaine, but about equally toxicity. Quick central nervous system effect that other than which can cause mental coordination and drowsiness and also other tinnitus and also the taste. So overdose can cause muscle twitchiness, cardiac arrhythmias, and falling blood pressure, and sometimes coma and respiratory arrest. It can also result in arrhythmias. So you have to be very careful when you're injecting this type of drug. It is available in injections, topical solutions, jellies, and ointment, etc. The other one is McCain, which is topically used. It's a slow onset of action, long duration of action, 8 hours, used for infiltration and spinal nerve blockage and epidural, unique property, and yes, without a significant water blockage. So the good thing in this McCain type of local anesthesia is that amide is that it causes analgesic effect. So it is iron lipid soluble and iron distributed in tissues. As you know that drugs which are iron soluble in lipid are distributed in tissues, whereas drugs which are protein, they are go to the blood and less in blood. So more cardiotoxic than others, and other local anesthesia because other ones causes QT intervention in case and not given IV. Never give anything which is lipid soluble into IV. It is available as 0.25 milligrams to 0.5 injections. So conclusionally, we can say that local anesthesia, like procaine PK is 9.1 and it is slow acting, duration of action is 45 to 90 minutes. So if you are going to work within 45 to 90 minutes, then it's a good one to use. The most commonly used is liginocaine, which is 7.9 pKa and it's rapid, 5 to 15 minutes. Then duration of action is 120 to 40 and the dose is 4.5 milligrams per kg body weight to 7.5 milligrams per kg body weight. So bupivacaine is 8.1 slowly acting and 4 to 8 hours and 2.5 milligrams per kg body weight. So the key one is liginocaine, which is most commonly used in our setup. So there's other ones we call them amines like you take it mixture of rock anesthesias. Two sodium substances mixed together is equal quantities by being from weight from you take it mixture and the melting point of this mixture is lower than the melting point of the individual components. So the purpose one is that you have to mix this type of molecules so that you can reduce the melting point of these molecules. So liginocaine and procaine combination is indicated for demo anesthesia. Specifically, designed to prevent pain associated with intravenous catheter, insertion, brand sampling, and superficial surgical procedures, and topical anesthesia of legs, ulcers, and cleaning or debridement. It can also be used to numb the skin before tattooing. And before tattooing, that is the most common areas it is used. Sometimes this one also cream can be used to this type of combined. It can be used to delay premature ejaculations in productive health. There's other ones, we call them like tetracyclines, which is 0.5% adrenaline, which in a equal of 1 to 2,000, and the cocaine of 10%. Topical anesthesia makes it found to be effective for non-musculoskeletal laceration to the face and scalp. So basically, it is applied directly to the wound using a cotton-tipped applicator with a palm pressure that is maintained 20 to 40 minutes. Maximum dose for children is 0.05 ml per kg, and toxicity due to toxin, due to cocaine. That is an example of MA applications of the skin. So the clinical applications techniques of local anesthesia is you can use surface anesthesia like mucous membrane and unblinded skin. You can use it on the nose, mouth, bronchial tree, cornea, and urinary tract. That is when you use lignocaine and tetracycline. They are used in these cases. Now, to infiltrate anesthesia, you use direct injection of the tissue to reach nerve branches and terminals, used in minor surgeries, incisions, androcele, and angiography, etc. So, failed block, you give injection of local anesthesia subcutaneously, aims to anesthetize the region distal to the site of injection. Examples is forearm, anterior abdominal wall, and scalp and lower extremities. Then you can do nerve block. Local anesthesia is injected around the nerve trunk or plexus. Areas of anesthesia is large in comparison to the amount of drug used. Last longer than the field or nutrition methods. Bonding technique for plexus blockage. Examples is trigeminal nerve blockage of the face, ophthalmic nerve blockage in iris and scalp, and suborbital nerve blockage for forearm. So a spinal anesthesia set of injection is a subarachnoid space between lumbar 2 and lumbar 3, and sometimes you can even do it in 3 and 4. And set of action is nerve root in the cauda equina, and sometimes it can cause what is called cauda equina syndrome. So level of anesthesia is speed of injection, velocity and of drug solution, and CSF and posture of the patient. So order of anesthesia is sympathetic, leading to motor. So Roe uses lower limbs, pelvis, lower abdomen, and prostatectomy, fracture setting, and obstetric procedures. Problems is spinal hypertension, bradycardia, and respiratory depression, cauda equina syndrome, and nausea and vomiting. So the drugs in this one is lignocaine and tetracycline in spinal anesthesia. Then we have epidural and cauda equina anesthesia. The site of injection is sacroiliatus, or condyle, lumbar, thoracic, or cervical region. Catheters are used for continuous infusion, and unwanted effect similar to that of spinal, except less likely because of longitudinal spinal spreading is reduced. Drug is lignocaine, novocaine, and lidocaine. Danger anesthesia is intravenous, like injection of local anesthesia in a vein of tourniquet, concludent rims, mostly limited to lumbar limbs and other orthopedic procedures. That is the time we use this regional anesthesia. So you can see this one about the epidural anesthesia. You will do that around this area, you do around this area, the dura, and then you can see the cauda equina, the filament terminates, and the so you can see it, and then you can do epidural space in cauda equina. So local anesthesia and desirable characteristics, it is rapid onset of action, brief reversal blockage of the nerves conduction, low degree of sedative toxicity, serve in water and stable solutions, effective on all parts of the nerves systems and all types of nerve fibers and muscle fibers. And you can see the new techniques of odontoplasty, local shock response, which is currently used. This is where the sponge is locked, and then it is used to for purpose of local anesthesia. It's the current technology. So you also another technique is